Bismillahirrahmanirrahim. In this lecture, we are going to study about the diagnosis of the myocardial infarction. ये किस तरह myocardial infarction को diagnose किया जाता है. So it is mainly on three bases: the clinical findings, based on the ECG changes, and it is based on the serum cardiac markers. So first of all, talking about the clinical findings. So myocardial infarction is characterized by the symptoms like severe crushing chest pain, and this mainly radiates to the left jaw or arm, but they are not relieved by the nitroglycerin. There is also marked diaphoresis or sweating. There is marked dyspnea, and it is also characterized by the heartburn. Now coming toward the ECG changes, so myocardial infarction show that there is ST segment elevation or maybe depression if it is subendocardial infarction. There is T wave inversion or there is deep Q wave. As you can see that there is ST segment elevation or maybe depression, there is T wave inversion, and there is a deep Q wave. These all are the signs of infarction MI. Coming toward the serum cardiac markers, so the first one to appear is the myoglobin, and it is the first to appear, and it becomes normal within the 24 hours. But the problem is that it is non-specific. It can be raised in other conditions like anemia, etc. The second one is the lactate dehydrogenase. It is also non-specific, but it has two forms: the lactate dehydrogenase 1 and the 2. The 1 is the cardiac specific and the 2 is the non-specific. So if we measure the ratio of 1 to 2, and when it is greater than 1, then it shows that there is myocardial ischemia. The lactate dehydrogenase reaches the peak at about 3 to 6 days, and it becomes normal in about 24 hours. As you can see in this picture, this is the myoglobin. It comes to normal in about 24 hours and peak at about 8 to 12 hours. The second picture is of the lactate dehydrogenase. It starts to raise about 60 to 20 hours after the myocardial ischemia, become peak at about 3 to 6 days and become normal in about 14 days. This is the picture of lactate dehydrogenase. The third one is the troponin, which also have two isoforms: the cardiac troponin C and the cardiac troponin I. The cardiac troponin C and the cardiac troponin 1. These are the most sensitive and specific one to the myocardial ischemia. They rise in about 2 to 4 hours, reach the peak in about 24 hours, and they become normal in about 7 to 10 days. So these are the most specific and sensitive serum cardiac markers of the myocardial ischemia. You can see this is the graph of the cardiac troponins. It started to rise in about 2 to 4 hours, become and reach the maximum in about 24 hours, and then start declining or become normal in about 7 to 10 days. The fourth one is the creatinine kinase, and this creatinine kinase has three forms, but the one which is called the MB, creatinine kinase MB, it is much more specific to the myocardial infarction, and if it is raised, then it shows the reinfection or reinfarction. Reinfarction occurs after the initial myocardial infarction. The creatinine kinase MB rises in about 4 to 6 hours, reaches the peak in about 24 hours, and it returns to normal in about 72 hours. But this show reinfarction. You can see the creatinine kinase graph. This is the creatinine kinase R. It reaches the maximum in about 24 hours, and then become normal in about 72 to 80 hours. Coming towards the treatment. So what is the treatment of myocardial infarction? So we usually give the aspirin and heparin, and this aspirin and heparin, the purpose of aspirin and heparin is to limit the thrombosis. thrombosis. We also give the supplemental oxygen to minimize the ischemia. We also give nitrates, and these nitrates are given in order to vasodilate the coronary arteries and veins. We also give the beta blockers, and the purpose is to decrease the heart rate and thus decrease the oxygen demand. And also we give beta blockers to decrease the risk of arrhythmia, because beta blockers is a second class antiarrhythmic drugs. We also give ACE inhibitors, and the purpose of ACE inhibitors is to decrease the left ventricular dilation. Because the ACE inhibitors will inhibit the angiotensin, and this will in turn leads to decrease in the blood volume and decrease pressure on the left ventricle. We also give fibrinolytics or do angioplasty, and the purpose of this is to restore the perfusion of heart, but this can lead to the following complication. This can lead to this fibrinolysis or angioplasty, which restore the perfusion or cause reperfusion. This will lead to the following complication like the reperfusion injury. And the reperfusion injury occurs due to the return of oxygen in inflammatory cells. This oxygen and inflammatory cells will result in the formation of free radicals, and this will in turn damage the protein and lipids in the myocytes, and it will cause further deterioration of myocardial infarction. The second one is that as there is recruitment of the inflammatory cells in the form of leukocytes, so these leukocytes will aggregate and will occlude the microvasculature of the heart, which will in turn cause the cell death. It can also produce the destructive enzymes like proteinase, etc., which can lead to the myocyte death. So the first complication is in the form of reperfusion injury caused by the oxygen in inflammatory cells. The second one is the reperfusion of the irreversibly damaged cells result in the cardiac influx. There will be much more. The second one is that reperfusion of the blood will allow much more calcium to enter the irreversibly damaged cells, and this calcium will cause the myofibril hypercontraction, and this will in turn lead to the cytoskeletal damage, and this will cause the cell death. And this cytoskeletal damage is mostly seen as the contraction, and this cytoskeletal damage is seen as the contraction band necrosis, as we have discussed in the morphology of the myocardial infarction. So these are these contraction bands necrosis due to the cytoskeletal damage. So now coming towards the complications. So the first complication of the myocardial infarction is in the form of contractile dysfunction, and it is mainly manifested as the hypotension, pulmonary congestion, or in the form of edema. In about 40% of the myocardial ischemia leads to the cardiogenic shock. The second one is the papillary muscle dysfunction, and this will lead to the regurgitation. The third one is the right ventricular infarction, and this will lead to the pooling of blood in the veins. The fifth one is in the form of cardiac rupture, which can be manifested as the cardiac tamponade, cardiac tamponade. The sixth one is in the form of arrhythmia, and it mostly occurs in about 90% of the patient with myocardial ischemia. The seventh one is in the form of pericarditis. The eighth one is the cardiac dilation. The ninth one is the mural thrombi, and the 10th one is the aneurysm. So these are the complications of the myocardial ischemia: contractile dysfunction, papillary muscle dysfunction, right ventricular infarction, cardiac rupture, arrhythmia, pericarditis, cardiac dilation, mural thrombi, and aneurysm.